So for the meeting, first person I have to welcome is Dr. Murli Raj. He is the president of the NNF chapter and a consultant neonatologist at Kraft Hospital, Kodungalur. This meeting is hosted by IAP Thrissur and NNF. I thank the president and for all your office bearers to be working with us so that we can participate in all the activities in a very smooth manner. Welcome, sir. Now,
Thank you, madam.
all the panelists, Purushothaman sir, he is the ultimate in the subject, giving us throughout the discussion. Then Janaki, welcome Janaki, simple in her ways, but pediatrics just flows in her blood. Hello Janaki, welcome, we are waiting. Second, Dr. Srini, who is the consultant neonatologist at Amala Hospital. More pediatrics is flowing with a wife as a pediatrician. Welcome to you, Srini. Third person is Dr. Lola from my own hospital, the professor in obstetrics and gynecology. Other than gynecology, she has some extracurricular interests. I don't know if you all know, she fell into fame in the TV show Ningalko Avam Kodishuran with Suresh Gopi. And she has some talents like saying some Malayalam words backwards. So today after the show, she will surely tell us that. Agree, Lola?
Okay.
Then the fourth, not the least important member, Dr. Praveen, always up to date in the subject of pediatrics. Welcome to each and every one of you. Welcome to my Vice President Sunil, Srijit, all our senior members, Parvati Madam, Saroja Madam, our past President, Dayanand sir. I can go on. Welcome to everybody. I'm so happy that all of you all have joined in. Let us move on to the subject fast. And Dr. Murliraj, I request you to start the program.
Yeah. Thank you, madam, for the kind words. Now I'll start my sharing the screen. Yes. So, friends, senior practitioners, welcome to a unique panel discussion on the issues of breastfeeding that we face in day-to-day life. So, I have a disclaimer to start with. This is the disclaimer. Breastfeeding is best for your baby. We support exclusive breastfeeding for first 6 months of life. These two sentences we do hear a lot of times in each and every formula, each and every infant milk substitute, each and every powder, it is there. So I was fascinated to see this painting which came into social media a few days back. A mother breastfeeding her baby. You can see that the roots of that tree is in her breast and the leaves, fruits, everything is there in the brain of the baby. But there is a problem with this one. As the painting shows, life is not a black and white one. We do have babies who feeds on plenty of breast milk, and we do sometimes have babies who do not even have the taste of a drop of breast milk. So life is not black and white. Life is colorful. There are a lot of shades of colors in between black and white. We do have babies who have breast milk, but they are flooded with the formula. Maybe we do have babies who little bit breast milk, and they have predominantly formula fed babies. So today we will see what went wrong. The opponent is strong. We know the opponent. Who is the opponent? Formula is the opponent. And the person is very, very strong. You might have seen this film, Diva, which was released in early 1790s.
Actually, we have some connectivity issues and actually Murali Raj is locked out. Even though the Zoom is the best platform, available platform, this type of technical glitches can do occur. Kindly bear with us and Murali will be joining us shortly.
അവസാനം യൂട്യൂബിൽ ലൈവ് സ്ട്രീം ചെയ്യുന്നുണ്ട്. യൂട്യൂബിൽ ഇപ്പൊ ലൈവ് സ്ട്രീം ചെയ്യുന്നുണ്ട്.
Murali, actually, you are not audible now. There's some problem with your
യൂട്യൂബ് ലൈവ് സ്ട്രീം ലിങ്ക് ഞാൻ തന്നു നോക്കാം.
Murli, we can't hear you. Murli, we can't hear you.
Yes, yes. Now it is visible.
No, it's visible, but it's not audible.
Yeah, it is audible now.
now it's about to audible.
Oh.
Once more.
Am I audible now?
Yeah, right. Yes.
Hello?
Yes,
Not
correct.
audible.
Yes, yes.
Hello?
Yes,
Audible now?
yes.
Yes,
Yes, yes,
Yes.
yes. I'll start. Can you see it?
Yeah, now it is clear and audible.
Yeah. So I'm extremely sorry for the technical issues. So
is it
what I
better you
was planning to say is that our restart.
Yeah.
ആ വീഡിയോ വേണ്ടെന്ന് പറയാൻ
I just muted all participants. Only the co-host now can talk, and co-host can unmute yourselves and talk. Murali, you can start, Murali.
Is it okay now?
Yes, right. Okay.
Yeah. Extremely sorry for the technical glitches. Yeah, I have started the presentation with this disclaimer, and already mentioned that everything is not black and white. There will be shades of colors in between black and white, and we have a lot of issues, technical issues like this will be facing in terms of breastfeeding also. And I already told that our opponent is strong and about this film. And this new generation, Amitabh Bachchan will be saying that I am easily available, I am plenty. My brother has way up to 100%. I have DHA and ARA, I have nucleotides, plenty of probiotics. I have a sister who is extensively hydrolyzed. I come from big factories and I have a lot of godfathers. And what do you have? What do you have? So Shashi Kapoor says, I have Ma with me. So friends, welcome to Amardut. It's a panel discussion in social, economic, political, and medical facets of breastfeeding. Myself, Dr. Murali, I am from Kodungallur, Thrissur, and panelists are Janagi Ma'am, who is the additional professor of pediatrics at Thrissur Medical College, Srinivasan sir, who is the head of Department of Neonatology, Amala Institute of Medical Science. Lola ma'am, who is Professor of Obstetrics and Gynecology, Jubilee Mission Medical College, and Praveen, who is coming from Kerala State Health Services. So this panel discussion is as a part of Breastfeeding Week celebrations, combinedly organized by NNF Thrissur and IAP Thrissur. And this is the theme of World Breastfeeding Week 2020, support breastfeeding for a healthier planet. So we come to the topic, breastfeeding. We know that it helps in preventing neonatal death. Within an hour, if you breastfeed the baby, it will prevent about 20% of newborn deaths. Surely it reduces the deaths due to sepsis, pneumonia, diarrhea, and hypothermia. And it has got a real role in under 5 mortality also. We know that pneumonia and diarrhea are the 2 major causes of under 5 mortality. And pneumonia, the deaths due to pneumonia will be reduced 15 times if you give exclusive breastfeeding. And also diarrhea will be reduced, death due to diarrhea will be reduced 11 times if you exclusively breastfeed the baby. So we know these things. We know this theory. Initiation of breastfeeding in the first hour of life, exclusive breastfeeding for the 6 months of life, and continued breastfeeding for at least 2 years. We reiterate these things. We reiterate these things to the patients, but we are pretty sure that these things will not work 100%. What happens globally? If we aim exclusive breastfeeding in first 6 months or first hour of life, 3 out of 5 babies globally are not breastfed in the first hour of life. And 41% of infants less than 6 months are only exclusively breastfed. The rest 60% are not exclusively breastfed. And about 8 lakh children could have been saved yearly if they were breastfed in the first 2 years of life. So this happens globally. What happens in India? As per the NHM survey, India has an institutional deliveries of about 78%, and 44% only we feed the babies in the first hour of life. And exclusive breastfeeding has only 65%. So my question to Janaki Madam is, since you are working in a tertiary care hospital, what are the practical difficulties you face in initiation of breastfeeding in the first hour of life? Madam. Janaki Madam?
Yeah, I practically grew up with BFHI. When I was in final year, or maybe when I was an intern in 1990, the Innocent Eye Declaration came into force. And then in 92, when I joined as a postgraduate student in pediatrics, the BFHI was Baby Friendly Hospital Initiative was started in India, and I was a delegate, a small junior delegate, helping with making the files, etc. In the first BFHI big workshop, huge workshop, which was conducted in Bombay. And I was taught by Dr. Kurian Thomas and Dr. Simeon Irani, who were the pioneers of baby-friendly practices in India. And so there was no need to convince me, and I was always part of this crusade. Now, this crusade has been going on for the last close to 25 years. And I have been involved with teaching nursing students, teaching medical students, teaching house surgeons, interns, PG students, gynecologists, field workers, etc., for so many years, and struggling and trying to get babies to feed within the first hour in the labor room. And it has not really happened till very recently. That was October of last year. Now, what happened in October last year? In October last year, there came the Lakshya initiative from the central government, from the NHM, whereby the labor rooms all over India are now trying to get accredited. So accredited, and with this new quality initiative. Now, this is a great thing, because now the obstetric side is also in the loop. They're per force in the loop, right? Now, the thing is that in a tertiary care hospital, in a tertiary care center hospital, tertiary care hospital, public sector hospital, it may not be the same obstetrician seeing the patient every day, every time she comes. So this time it may be the unit chief of the O3 unit. The next visit it may be the resident of the O3 unit. The next time it may be the lecturer in the O3 unit. The delivery is taken by somebody else whom she doesn't know. And then when she comes for her follow-up too, it is somebody else in the same unit. So that continuity of care doesn't occur. Unlike babies who are born in hospitals outside these large hospitals, where the same obstetrician sees her lady, her patient, delivers the baby, and the baby follows up with the obstetrician, so that they treat their obstetrician's words like words of God. And those obstetricians are probably able to enforce feeding and suggest that breastfeeding, exclusive breastfeeding in the first few months of life is very important. Now we have this initiative called Lakshya, and look at the do's and don'ts of the labor room, which you can see written there very nicely. Immediate clamping and cutting of the umbilical cord. Separating should be delayed. So delayed clamping. Separating baby from the mother for routine care and practice should not be done. Use of placing the baby on the mother's abdomen soon after delivery, and initiation of breastfeeding within 1 hour of birth. So they are all part of the Lakshya accreditation system. And since October, this has been happening very nicely in our hospital. Something which we have been struggling to do over the last 20 years has materialized in just a matter of maybe 6 months. So isn't that a great thing? So I think getting the obstetrician into the loop, into having a teamwork with obstetrician and pediatrician doesn't really happen in the big hospitals, probably because of the large crowds and the big departments. But this certainly will work in the periphery, and it probably is working also. What are the goals of this Lakshya program? The goals are safe maternity, safe babies, healthy newborn, and respectful maternity care. And once these things are put into practice, I'm sure we'll be able to close that gap. Another thing could be mandatory training of lactation counselors. And this too is part of the SNCU initiative. So this too will probably help to close the gap. Yeah. I think that's Murli.
Yes, Madam is trying to say is if you see that lecture guidelines, if you see in the left hand side, if you see the lecture guidelines, the don'ts are, I think majority of the don'ts are being done now, I think, because the induction of labor and physical abuse, I don't know, and conventional lithotomy and immediate clamping, cutting cord, separating the baby. So what 2-3 things we have to be in strict practice is, the one is delayed cord clamping at least 1 minute, and don't separate the baby from the mother. The baby is okay, he is not asphyxiated, he is breathing well, his tone is good, color is good, and time is gestation. Just keep the baby on the mother's abdomen or mother's, in between the mother's breast, and you can start breastfeeding the baby. So that is the first step in unit resuscitation program. Okay, and also initiate the breastfeeding within the first hour of birth. That should be the thing, and for that we know that pediatricians or things without the help of our friends, that is obstetricians. Okay, now we'll go to the private sector. Srini sir, do you feel that initiation of first hour feeding is difficult or easy in private sector? Why? And do your hospital or do private hospital maintain the post of a lactation counselor?
Good evening, everyone. Am I audible to all?
Yes, sir. Yes.
Okay. First of all, let me thank the office bearers of IAP Thrissur and NNH for giving me this opportunity to be a part of this panel discussion. To begin with, let's see the trend of breastfeeding indicators in our country. This is taken from our National Family Health Survey and RSC survey data. It is, if you see the first row, it is heartening to note that the early initiation of breastfeeding has improved from around 16% to almost 40 to 50% in the last couple of decades. Next slide. Okay, now coming to the question, like the initiation of first year of feeding in our hospital is easy now, but it was very difficult to start with because it requires a lot of conviction, motivation, effort, time effort by a team comprising of mothers, doctors, healthcare providers, and everyone. Okay. See, as a pediatrician or a neonatologist, see, we don't attend all deliveries, and we can put this idea and pass it on and convince everyone. We need to convince everyone. And usually, a pediatrician or a neonatologist is not available 24/7 to implement it. So every stakeholder should play their role. That is one thing. That is one thing that's important. Fortunately, I work in a private medical college where we have uh, enough people around to monitor or to enforce this. But sometimes, again, too many cooks can spoil the broth. So we need to make sure standard practices are followed. Second thing, in a smaller hospital, again, this might be a problem. The managing the number of personnel may be a problem. Second thing is accountability. Accountability is that, see, we are having a program which is running, or we are ensuring that every baby is getting early breastfeeding, but we need to make sure that this is strictly enforced 24/7. So a way to do it would be, most probably it is the staff nurse who's going to be around. So to record it in the case sheet where it has been done, and to get it signed and to cross check it once in a while. Okay. Now, I found this powerful statement in this COVID era regarding breast milk. Now, see, we are all looking for a vaccine in this COVID era, and breast milk can be compared to the cheapest, safest, and orally administered vaccine, where there's no cold chain is required and saves millions of babies. Okay, next slide. Next. Yeah, again, just to enforce a point, I mean, we are all familiar with the warm care, the essential warm chain, the essential care of newborn. What we are talking here is skin to skin contact and breastfeeding. These are probably the golden steps towards promoting and starting breastfeeding. Next slide. Coming to the second part of the question. Now, lactation counselor. Who is a lactation counselor? Lactation counselor is any healthcare worker who is recognized, who knows what is all about human lactation and all about breastfeeding practices. There are certified courses available in private sector as well as in the government sector. And lactation counselor works in a hospital setup or a clinic setup, both in private and public sector places. Okay. Now, honestly, we don't have a certified lactational counselor. Okay, because it does require a lot of economics in private sector. So, but what we have done is we have trained the dedicated staff. We have two nurses who are dedicated and who does this job mainly with regard to lactation counseling. Okay. Now, next slide. Next slide. Yeah. Now, we are all familiar with the MA training package for infant feeding program for healthcare workers, the 1 day, 4 day, and 7 day program. Now, coming to the guidelines regarding the role of lactation counselor, this I have taken from the BPNI guidelines there, which has come in January 2020. I'm not going into each and every aspect of this detailed guidelines. Next slide. But a few aspects which I want to, next slide, please. Here is one target audience, we all know, anticipatory counseling. That is where we expect breastfeeding can be a problem. For example, if the mother, I mean, this is mainly in the antenatal visit, mother has got a nipple issue. Now, this need to be addressed. Also, a mother who is a GDM, okay, the importance about breastfeeding can be addressed at that time. And breastfeeding counseling is done antenatally till the breastfeeding is usually advised till 24 hours, 24 months of life of the infant. Now, frequency of breastfeeding. Here, it is recommended that it should be provided at least 6 times. Okay. One is in the antenatal period, again, which I touched on. Then immediately after birth, it is in the first 2-3 days of life. Then we usually call the baby for a follow-up between 1 and 2 weeks. And it is very important to counsel again about the mother regarding whether she's following the proper practice of breastfeeding or not. Then around 3 to 4 months, this is when the mother starts getting ideas regarding supplementary feeding or stopping or adding a formula, etc. This is one time where you have to make sure the baby's mother is getting enough milk and mother is following the advice given, and she's this being what do you call it, enforced, whatever advice given is enforced. Then around 6 months, before 6 months, around 5 months, this is the time where we need to counsel regarding supplementary feeding. And another visit after 6 months where mother should not start weaning, but whether she has to continue breastfeeding and supplement along with supplementary foods. Okay. Now, the mode of counseling is not by giving a leaflet. It is a face-to-face counseling and a more or less a targeted counseling towards what the problem is there. Okay. Now, coming to next.
Yes. So what Sir has pointed out is the importance of lactation counselors. I'm pretty sure that many of the private hospitals are not having any lactation counselors because the management has to pay them. Who will pay them? So they will always look for shortcuts. They will entrust one nursing staff to counsel, and that person may not be so effective or not as good as those persons who have taken training in counseling. So we will see whether it is the government setup or it is available. Praveen, what's the role of lactation counsel? Do you think that posting a staff in the labor room or theater for the sole purpose of initiation of breastfeeding will help? Do you have such a system in your hospital or in Kerala Government Health Services? Praveen.
First of all, I will like to thank the organizers for giving me a chance to participate in this panel discussion with my Professor Janaki Madam and other senior members. I would like to point out some of the practical issues we face in peripheral institutions, especially in the government setup, where a lactation counselor is boost to the hardworking sisters and also the gynecologist. You may know that in Taluk Hospital, there may be 1 or 2 gynecologists or 1 pediatrician. He may not be available on every day, many other duties. So the baby may be seen on the next day only. In the initial phase, there will be some nursing assistant. They have to many other duties along with shifting the patient to the labor room and cleaning the instruments. So there is practically no one will be there to look after the baby. After delivery, the baby will be handed over the bystanders, the grandparents. They will keep the baby for us sometimes, and after all things are over, the sister will call the baby back to feed. That's happening in most of the government hospitals now. So a lactation counselor is an interested person who have scientific knowledge and training in lactation and counseling. That will be a helpful situation to initiate the breastfeeding in the initial hours. And also for gynec ward and antenatal ward, there will be a lot of admission and only 1 staff nurse for looking after the patients. she may not be possible to counsel the mother and relieve her anxiety. During that period, these lactation counselors can give better counseling for the mother. Usually, they have to be given scientific knowledge. But practically, what is happening that the bystanders or bystander of the another patient will give counseling that may not be scientific. When many myths are there, we know. So a designated trained person in labor room and antenatal ward and postnatal ward will be useful for a government setup, and they can do an effective counseling taking enough time, and also they can create a rapport. In different shifts, different sisters are coming and they have a lot of work, so they cannot create a rapport with the patient during the initial period. So as a single person attending patient will be useful. But this service should be extended to the after discharge also. After 2 or 3 days hospital stay, the patients are discharged to the home, and they may go to the father's house, then went to their home. So there is no continuity in seeing the patient. They will see a pediatrician only after 6 months. Sometimes they will come to the immunization clinic, but you know, the busy immunization clinic, there will not be any doctor to see and to give counseling for these mothers. So in government setup, it is usually not happening. So what now the IAP has taken a step this year to give training for staff nurses, but it is like we are making all work to one point, one delivery point. The staff nurse is the same person who is doing the lactation counseling, who is also the staff nurse has to take 12-hour duty to get a, off for the next day. Sometimes she has to manage the NBSU at the same time, and also the postnatal ward and antenatal ward at the same time. That's a staff shortage in government setup. So lactation council will be boost to the government system, but unfortunately, no such discussions are going on in government setup. No post of lactation councils are now there in government hospitals.
Yes, that's a very important point put forward by Dr. Praveen, that there is no post-op lactation counselors even in government hospitals. So, like Praveen told, if one person is willing to work, he or she will be fed up with work. So, a sister will be forced to do the lactation counseling. She will be forced to do that newborn care. She will be forced to do the maternal care, all those things. So I think IAP or NNF seriously has to take these things into consideration and train more and more people on lactation counselors and appoint them both in private as well as government hospitals. Madam, I have one question for you, that is BFHI. Probably this is the most important question in the entire panel discussion. BFHI emphasizes the need for antenatal counseling of pregnant women for the need of exclusive breastfeeding. Is it a routine or regular objective practice? Or what are the practical difficulties you face in counseling third trimester or the antenatal women regarding exclusive breastfeeding? Is a third trimester breast examination is routinely carried out?
Good evening, everybody, and let me thank the organizers for
Yeah.
Madam, you're not audible. Madam, I can't hear you.
I think some technical issues are there. Hello?
Madam,
I think we are facing another technical issue. I think madam is logged out.
Even you are not really audible. Srijit.
Yes, madam.
Even you are not very audible.
Oh, even I am not very audible. Actually, the today
it's wavering.
a problem with the bandwidth and all.
Now it's better. Now you're better. But where's madam?
Actually, madam is not seeing in the list. Actually, madam is logged out, I think. So, Murali, can we move to the...
What has happened to madam?
Murali's network was actually very problematic from the start.
I rang up Dr. Lola. She's trying for connection. So can we go on to the next question because she's trying to connect again. Dr. Murali?
He has also disappeared.
Okay, then I will ask Purushottam sir actually to take on this question, to comment on this situation. Not regarding the connectivity issue, but the problem facing in the first row of feeding. Regarding initiation of
today we were unlucky because the way I saw the meeting started, the excellent manner in which Dr. Reddy welcomed us. Really, I was jealous of the method, the language, and how you welcome. That's one thing. And Murali's introduction was fantastic. And then came all the speakers wonderfully doing well. Only thing maybe the without this net program, it would have been a very good panel discussion. All the relevant points were being discussed. I don't know why this happened.
Murali has come back.
Yeah, Murali has come back. Okay, let him take over. Okay.
Murali, can you hear?
Dr. Murali, can you hear us? Can you unmute and talk?
Murali, please unmute.
Murali will talk.
Yeah. It is my problem or
everybody's?
Yes, actually today everybody's very slow.
All is well that ends well. We met you. You have come in again, so we can start again.
Hello.
Yeah, it is visible now.
Yeah, it's visible.
Hello?
Yes, it's visible.
No, ma'am. I am extremely sorry for the technical glitches. I don't know whether.
Madam, no. Is Lola madam back? Yes, madam is coming. Madam.
Please unmute, Dr.
Hello.
Yes.
Yes, madam. Welcome back.
Yeah, thank you. I have joining from my mobile. The laptop was a problem. Okay, anyway. To come back to our answer, we don't, usually in busy obstetric practices, the time is very limited. So, and also lots of antenatal patients will be there, and there will be only one gynecologist to see all of them. So if you you cannot talk to a person for a very long time, and so that means there is lack of time, there is lack of personnel, and also like where you have some privacy to talk all these things. So because of all these, I think antenatal counseling is not very much practiced. Okay. Okay. Now, coming to the second.
Too much echo is there from your voice.
Actually, madam, if you're using two devices, you can switch off one device.
Yeah, I
Continue
stopped.
only with phone.
I have stopped the other device. Okay.
Yeah, now it's fine.
It's okay now?
Yeah, madam. You go on.
Now, in places where they have dedicated antenatal classes, some counseling is given during the antenatal classes. In the OPD per se, it is very difficult to give. So usually it is not given. Maybe a perfunctory, maybe in 1 or 2 sentences. Not a real proper antenatal counseling regarding breastfeeding is given in any, at least in our hospital or wherever I have worked. And another thing is the patients are not aware of its importance in the antenatal period. And also, like our setup, it is like a genie, like a dollhouse. We are looking only at the obstetric problems. We are looking whether she has preeclampsia, whether there is IUGR. We do not think about after the delivery, the babies should be breastfed. We are not actually in that mindset as yet. So we think that we should tell all these things only after the baby is born. So probably that is also one more reason why we do not tell such things in the antenatal period. Also, probably I think we all should be made more aware of that thing. And what was the third question? Actually, yeah, I lost the slide screen.
Only we have lost the screen. Only we have lost the screen. Only we have lost the screen.
Yeah, I'll share. Yes.
No, my last slide.
Is it visible now?
Yeah. Now it's there. It's come back.
Yeah, it's come back. But yeah. Now coming to the third trimester breast examination, that is also not routinely carried out. Again, the problem is the time and also the privacy issues, because when we look at the abdomen, it's okay. But when we have to ask her to expose her breasts, then again, you need privacy. Not only that, nowadays with the sort of dresses that people are wearing, the very tight dresses, it's very difficult to expose the breast part. So that usually the time you take to examine one patient, if you see the breast, you can see 2 patients if you see only the abdomen. And also again, we are not yet aware of obstetricians, I'm telling. We are not yet aware that it is that important, but it is really important, because after when the lady, we see that the lady has retracted nipples and all those things only after the baby is born. We don't really, I have to confess, we don't really look at the breast in the antenatal period, truthfully speaking. So all these are really, all these are the deterrents
That's a very
in the antenatal period.
Yeah, that's a very important statement that many.
Very candid statement.
Yeah, it's happening.
Yeah, that's a very important thing, because majority of the time when we see the newborn, and when we see the newborn and the baby will not be feeding, and when we see that there is this retracted nipple, a large nipple, inverted nipple, all those things.
Then the mother
can be corrected in the antenatal period itself. Will be a very great help in establishing the exclusive breastfeeding within the first hour of life. Even in the first few days, if you want to establish the breastfeed, the nipple should be there, isn't it? So it's a very simple thing, but that has to be looked into. Thank you, madam. Now, after the Indian data, I'll come to the Kerala data. In Kerala, it's clear that almost all our deliveries happens in institutions, and all the deliveries are attended by a skilled healthcare provider. But our exclusive breastfeeding rate is only half. So we have hospitals, we have adequate facilities, we have skilled health providers, but still we lag behind in exclusive breastfeeding in the first 6 months. Janaki ma'am, so what will be the cause? We are only 50% into our exclusive breastfeeding. What may be the cause?
Can I have the slide, please? The slide. Can you hear me? Only can you? Yeah. So
can you hear me?
Yeah, right. I can hear you. Now, one thing we went into very well with Dr. Lola,
Yes.
and that
Yes,
is,
slide is there, ma'am.
yeah. Can you hear me? Can you hear me? One
Yeah,
thing
yeah,
we went
yeah,
into,
yeah, yeah.
we went
Here,
into
here.
very well with Dr. Lola, and that was inadequate antenatal counseling regarding the importance of exclusive breastfeeding in the first 6 months. So the mother has to know about the importance of breastfeeding. She needs to know that her body
Yes,
has to be
yes.
prepared for it. She needs her breasts to be examined and to be and to be told how to prepare her breasts, how to look after retracted nipples before the baby is born, so that we can start initiating breastfeeding as soon as the baby is born. And she also needs to be exposed to the right kind of media. Now, social media is so important, and TV and books that she reads, the papers and the periodicals that she reads, they need to give the right messages. And we need to really actively discourage the wrong messages. So there is a lot of pressure on marketing, of pressure from the commercial pressure from companies marketing infant milk substitutes and baby food. And we need to be able to stop that at some point, or resist that pressure by, in some way. Like, of course, we are a huge organization. The IAP can easily resist all this. Why should we carry advertisements of Horlicks on our journal, on our esteemed journal, Indian Pediatrics? We have, haven't we? When I was a final year student, I remember that we didn't have our IAP quiz. We had our IAP quiz, but then halfway through it had to be abandoned because Nestle had been supporting the IAP quiz. And then the innocent, like I said, the Innocent Eye Declaration and the Baby Friendly Initiative came along, and the IAP quiz was suspended for a year because Nestle was supporting it. Now that kind of activism is not there anymore. We aren't really getting involved with that kind of activism. And the other important thing is we lack a streamlined follow-up of our neonates. And so there are guidelines. For example, the SNCU, that's the Sick Newborn Care Unit follow-up guidelines, mandate that the baby comes to us first at 2 weeks, and then at 6 weeks, and then at regular intervals till 1 year, and that an ASHA worker checks on the baby 1 week after delivery and follows up the baby there and intervenes at any point. So they check the weight, they're supposed to check the weight, find out if there's failure to thrive, see that the baby is feeding well, see that they get the immunization, check on the development, all that. But is it really working? Is that system really working? And there is such a beautiful there's such a beautiful registration booklet which is given to the mother at the time of registration, antenatal registration. I'm sure Praveen must be knowing, and many of our colleagues in the health service must have seen this. It's such a beautiful book with good advice regarding antenatal care, the baby, care of the newborn, lactation, development, immunization, feeding, and so on. But you look at any mother's handbook when she comes to get admitted in the newborn ICU, when the baby gets admitted in the newborn ICU, you look at that handbook, the name is written on the front, and then the BCG is entered in the back, and that's it. There's nothing more. So there are so many nice things in place which are not really utilized. So that's one thing. And another thing is that in Kerala actually ranks 6 on the infant feeding score at an all India level. And the survey was done in August 2019. So data was released by the Ministry of Health and Family Welfare in 2019 August. And we actually ranked 6. So we are not so bad at all. Among the large states, we are actually ranking 6. I mean, among all the states, we're ranking 6. And the states above us are small states like Puducherry and Mizoram and something. So we are actually doing pretty well. So a lot more of advocacy and a lot more of interventions on our part will probably work well, and we could bring this number up from 55 and 60 up to 100%, or at least 95%. It's not impossible. Yeah, Murli. Murli Boya. Murli, you're not audible.
Yeah. I was muted actually. So we have
Dr.
seen that in the
Murli.
previous slide. Audible? Yes, I am here. Hello? Am I audible?
Murli, continue. No problem.
Audible.
Yeah. Yes. So my next question is to Praveen. In that case slide, we have seen urban and rural difference in the prevalence of exclusive breastfeeding in Kerala. In the urban area, it was 65%, whereas in the rural area, it was 53%. Praveen, what do you think? What is the cause of this difference in the feeding rate in the urban
Can
and
we
the
hear
rural
Dr.
area?
Murli? No.
Praveen.
Praveen.
Yeah, I am here. Praveen, can you hear me? Hello?
Actually,
Praveen.
this is also
Hello?
Is
Praveen.
Dr. Praveen
Today is
there?
having a lot of technical glitches.
okay. Then actually, Murli, can I
Dr.
ask?
Praveen?
Actually, can you pass on to the next panelist, and we'll come back on Praveen. Actually, I have muted all the participants.
Response which is given to me by Praveen. Hello? Okay. Hello? Am I audible now? Yeah.
Yes.
So this is one of the most important things, that is cesarean section and breastfeeding. In this slide, we can see that the National Family Survey 4, we can see that cesarean section is very much prevalent, especially in the south. That Kerala is coming to about 36%, whereas WHO recommends the rate of CS to be less than 15%, 15%. So we can see one of the, we see that this on the right hand side, we can all those states that Tamil Nadu, Kerala, Andhra, Telangana, and Karnataka all have cesarean rates very high. Even a state in Telangana, which is Karimnagar, which has got a cesarean rate of more than 80%. So my question is, do a high cesarean rate have an association with a failed initiation of breastfeeding in the first hour of life? And what are the remedial actions taken by FOXI or KFOG to improve the exclusive breastfeeding practices?
Yes. Yes, probably. Yeah. Probably it plays a part. The high cesarean section rate, it does play a part, I feel, in reducing the rate of initiation of breastfeeding in the first hour of life. And we all of us are actively trying, KFOG, all of us in KFOG, we are actively trying to reduce our cesarean section rates. But I think it will take some time. But yes, it does play a part. And coming to FOGSI, FOGSI has a breast committee, which carries out a lot of programs to improve exclusive breastfeeding practices in India. And this year, they have held webinars. They have conducted posters, slogan, and video competition for its members to increase their awareness regarding breastfeeding and the antenatal counseling. And also the milk bank, they are just starting. I think we have 2 centers in Kerala. So that also may help in improving the supply of breast milk to the babies. So, all these having, and KFOG per se doesn't have any activity, but that is because all of us, like Thrissur OG Society, Kannur OG Society, all of us are members of Foxy. So individually, as we all are units of Foxy, we carry out the instructions of Foxy, doing all these programs in our areas. So KFOG per se doesn't have, we all the individual societies, we carry out all these activities, and these are all the activities which have been done this year by the breast committee of Foxy. So yeah, that's all.
So probably we cannot, sometimes we cannot bring down the cesarean rate. I don't know, something that has to be. They are given some other fluids like water, something like that. So my question is to Srini sir, what may be the important causes of supplementary feeding in an otherwise breastfed baby who is less than 6 months of age?
Hello, am I audible?
Yes.
Yeah, now I just recap on the data which already we have gone through. When you see the national survey, you can see that exclusive breastfeeding is not up to mark in the national data. It is still around 50 to 60%. So let us see a few scenarios where we typically find. Next slide, please. Next slide. So here, it could be a genuine medical condition. It could be a genuine medical condition which is affecting the mother or the infant, in which case we need to deal with it appropriately. Most important scenarios are, one is a lack of awareness or motivation or anxiety on the part of the mother. This is what we typically see in the OPD, working mother, baby around 3 months or so. When the mother is thinking about her joining back to work, and she's thinking whether her breast milk will be adequate, already these thoughts have started affecting the prolactin axis, and she's having a reduced blood supply. This is reduced milk. Okay, this is one scenario where she may be tempted to start a supplementary feeding or even a formula. Okay, the answer to this lies again in motivating and probably legislation with regard to maternity leave and all. Okay, now the second scenario is another scenario which we find in our sort of hospital, where you have a well-fed baby. The mother's complaint is the baby is feeding frequently and is always crying, and whether I'm worried whether the baby is getting adequate milk, and he is already started on kurku. And when you examine such a baby, the baby has already more than doubled his birth weight, and that chubby fellow is grinning at you. Okay, this is the typical colicky baby that you get, and we know the reason for this colic and all. So what is again needed here is to emphasize the importance of feeding technique and the interval between feed, how to feed the baby, let the baby go on to demand feeding, all those texting, which again, counseling is going to help. Now, another scenario is social pressures. This is usually in our setup, the mother is in her mother's house till 3 months, and around 3 months starts to socialize. Other people come to see, and then they pass comments like the baby is very small, or the neighbor, or even sometimes healthcare professional, or a UGR baby who goes for immunization. No, a comment is passed that the baby is not put enough weight. So this is another scenario where the mother is tempted to start additional or supplementary feeding. Okay, here again, one more point which to emphasize during counseling as from our side is that use a growth chart and demonstrate what is the actual weight requirement, the weight gain required, and explain to them about the qualities of breastfeeding. And again, okay, now we already discussed about advertisement and social media pressures. Okay, I'm not going to do this. This is another issue which we need to maybe with legislation or other matters. So the solution lies in educating and counseling the mother and even the caregivers. And probably, since we are all pressed for time, again, the need for a lactation counselor or a person dedicated to counseling is emphasized here.
Yes. 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 Thank you, sir. Thank
you.
Thank you, sir, for initially, but I think this is partially answered by madam. My question is, we have a lot of laws to prevent the distribution of substitutes. It is effective, or can you say where thing we have partially answered previously, but you can again take it.
Yeah, we all know about the. Can you hear me? Am I audible? Can you hear me?
Yes, you're audible, Janvi.
Yeah, fine. So we all know about the International Code of Marketing of Breast Milk Substitutes, and we all know about that.
Yes.
And this was a recent report that was in 2016, which was jointly brought out by the WHO, the UNICEF, and the IBFAN. Now, IBFAN is the International Baby Food Action Network. Now, this report examined the status of national legal measures. So, how far have different countries really enforced the code? The code, they put it in inverted commas and they call it the code. Now, you can see that India, and we should be proud of the fact that India has enacted all the provisions of the code as law. It is legal in India, has brought legitimacy to it in our country. Whereas there is no legislation at all in a developed country like the United States. So we are actually very far ahead. And I really think it's a human rights violation, is it not to have such a legislation in place and leave it as a choice to the mother. Do you want to breastfeed, or do you not want to breastfeed? Anyway, so that's besides the point. But out of the 197 members of the WHO, so 197 countries are member countries of the WHO, only 39 have registration, have legislation reflecting all the provisions of the code. So that's so interesting. Only 39 out of 197 countries have legislation which has all the provisions of the code. And out of those, only 6 have a dedicated budget or a fund to implement this code. And again, we should be proud of the fact that India is one of those 6 countries. So we have a dedicated budget, and our laws completely accept what is given in the International Code of Marketing of Breast Milk Substitutes. So as far as legislation goes, we are wonderful. Now, what about implementation? Now, how do you know whether implementation is really going on in the right way? You need to have a monitoring system in place. As far as monitoring is concerned, our system, again from the same report, our system monitors retailers. It's supposed to be monitoring the media, and it does not really actually monitor the healthcare facilities. And according to this code, in 2016, there was no transparent. This monitoring system was not transparent, and it was not free from commercial interests. So they're very clear about it. In this same report says that there is inadequate monitoring of health facilities, there is monitoring of retail outlets and of the media, but none of this is free from commercial interests, and none of this is transparent. So this is the reason, this is the status of legislation in India. And what we need now is stringent enforcement and strengthening of the monitoring system. And again, here IAP has a role there for activism and advocacy, more of activism here to close these loopholes. So all this legislation has loopholes, and those loopholes are the lack of transparency and the point that they say that we are not free of commercial interests. So all those loopholes in the laws probably have to be addressed. Is that okay?
Okay. Praveen is there? Praveen? Praveen?
He's there. Please unmute Dr. Praveen. Dr. Praveen, please unmute yourself.
Yes, sir.
Yeah. I have one question, Mr. for you. Okay. Yeah. Now we can answer this. The role of this print, visual, and social media in promoting exclusive breastfeeding. And there we see a lot of advertisement in that media. And do you think that this will of exclusive of the goals of BFHI?
Yes. Actually, media is one of the pillars of democracy now. You know, the life experience is mediated through technology rather than real experience. Many of our experiences are we are sharing through medias, and now new media is coming, social media platform, very informative. At the same time, very misconceptions are also spreading through social media. So I don't know whether the policymakers and media outlets are recognizing the power of this media or properly utilizing them. What we see is that many of the mothers or caregivers are using internet, and they will ask us about the usage of milk substitutes and even the formula feeds and even Pediasure, like many substances they are netting, searching for in internet and coming us and asking us about that. And many of our doctors are also prescribing these milk substitutes many times. At the same time, in visual media, you can see many advertisements are there showing the chubby child, and they will give a false image that your child should be like this and not like you. Your child should be like a chubby girl or baby, and that image creation is very important. Image, and also they are very unauthentic messages are mainly through these WhatsApp groups and social media. Many unauthentic messages are spreading, and many public figures. Now there is a legislation that you should not participate in do an advertisement which is misleading. But many times public figures are also there advertising in advertisement groups. So here the role of IAP is coming. You can see the IAP has intervened in many issues like reducing the school bag weight, even though it's not that successful. But here IAP should take an active role, and we should promote a video using a famous person promoting the breastfeeding aspects. And we can utilize this media, visual media, YouTube, and also the social platform. But we are in government setup, we have a Facebook, we have a website like Amritakiranam, which was started in 2014 and 16 by government doctors, which spreads many of the scientific knowledges. Many of our members are writing on this, and this scientific knowledge, sir, we are sharing through WhatsApp groups also. And in health service, how we can use this system is that in every ward there will be an ASHA, and ASHA knows all the household members' phone number. And what we are doing now, this corona period, not only this corona period, before that we are asked this ASHA or the municipal worker to create a WhatsApp group. Many of the municipal councillors will have that WhatsApp group, and this WhatsApp platform we are utilizing to spreading messages from government, and also spreading this health education. And now it's also very useful, finding out very useful. They are asking us what all messages we can share. You please share into our group. There is also a group we are creating name of Arogya Jagrata, that is mainly for these epidemic diseases. But these platforms are very useful. We can utilize this platform to spread this news to Anganwadi workers, ASHA workers, and also to the mothers. So WhatsApp groups are very useful in current scenario, but we are not utilizing it in the proper way. And also authentic write-ups that should come in every visual and print medias. Many times when we are doing a post in social media, the printing medias will contact us to take that post from them. So they are not getting a proper messages through a authentic simple and simple language, and very useful messages are not getting. So IAP should create a panel which will regularly giving write-ups to these visual and print medias, and they should use their connections like media persons. And they should also one video we have seen this time from Dr. Krishna Mohan from Calicut, very useful video. I used that video link, and using this video link we are trying to show these videos in antenatal ward using our projector in PP unit. So that type of videos are very useful. The antenatal ward mothers are very anxious, and they are after post CS they are lying down. So when we are giving a visual media to antenatal ward, postnatal ward also, that will be very useful, and that will be impressive. At that time they will hear us. Other time they will not hear. But when after post surgery or after delivery, first 3 days, these visual medias we can use. For next slide. Next slide, sir. Murli sir.
Okay.
Next slide.
Okay. Yeah.
One question was there. Negative influence of advertisement. So the as we know, the advertisements are always exaggerated, and they are creating a false image, and also highly influential. So as Janaki Madam said, the law enforcement for breastfeeding, also the law enforcement has came down now for controlling the media parts where false advertisements are restricted now. So I think IAP has a major role.
Yes. Your points are clear, because the other parties using media, social media, we can also use the same thing. Social media and media can videos, everything will be very useful. So we will come to some medical breastfeeding and exclusive breastfeeding. There was an argument, some people that that formula use was increased when, and it is developed as a subspecialty of pediatrics, or otherwise known as neonatology. So what they other is diabetes, not having. So
hello, am I audible?
Or
Yeah, sure.
Yes, sir.
Yeah. Next slide.
breast milk
Only next slide. Okay, see, this is a very serious question or a common problem. The previous one. Murli, the previous one. Okay, this is a hypoglycemia is a serious problem which we all encounter, and it is a preventable problem. Okay, and most important thing is to that point is that symptomatic hypoglycemia leads to very serious consequences, and we are not aware of the medico-legal issues in which is raised in all the conferences. The typical MRI findings in a baby with a sequelae due to hypoglycemia. Okay. Now a little bit about hypoglycemia. See how the newborn has a lesser glucose requirement when compared to adults, and a newborn brain can use, besides glucose, it can also use ketones for its metabolism. So we are all familiar with this hypoglycemia wheel. Okay, I'm not going to the details of that. Most important point here is that threshold regarding the glucose level is lower. Okay, and a symptomatic newborn need to be identified early and intervened. Now, how do you do that? Okay, going to the next slide. See, how do you deal with that? One is you are going to anticipate the high risk group. We all know which are the group of babies apart from a mother with gestational diabetes who may go in for hypoglycemia. So we need to identify them early and preferably counsel regarding breastfeeding, especially in a mother with GDM. You may be able to counsel antenatally if there is an issue like a nipple issue and all can be dealt early in this case. Then you assign a responsibility of feeding the baby to one of the caregivers. Okay, because as far as possible, we try to room the baby with the mother. That's the whole idea of promoting breastfeeding. So mother may not be in a position to do everything on her own. So she need to be encouraged to feed by a responsible caregiver, and this caregiver also need to be told what to look for with regard to the symptomatology, the symptomatic hypoglycemia, the symptoms of hypoglycemia. And we have to monitor these babies. We can use any standard protocol and intervene as per the symptoms or as per the requirement. Okay. Now, counseling again, antenatal counseling regarding breastfeeding formula, breastfeeding, and as well as counseling or assigning the responsibility of caregiver or whoever is most important to prevent hypoglycemia. Okay, advising infant formula should never be used as a shortcut in this scenario. Okay.
Yes. So even you get a baby with a mother having gestational diabetes, is there doesn't crash land. We know that it is an expert hypoglycemia, and antenatal counseling, breast examination, and also postnatal monitoring should be done. So this is pretty. Sometimes we see cases like a baby who was put to 15 to 20% of weight 3 days on this, and when you seems to be 60. Praveen, find decision in your case, or is it real breast milk?
Sir.
Praveen.
Am I audible? Sir, next slide.
Yeah.
Next. Sir, these conditions are not very rare. We usually find the dehydration fever, but in government center, we are not supported with the lab, so we cannot record these findings. But the jaundice also we witnessed during the summer periods. And one problem what we are seeing in government setup is that there are a lot of patients crowding in same ward. There will not be a fan at all sometimes. So dehydration is a possibility, and caregivers like the grandparents are not giving enough water to the mother especially after a cesarean section. They will not give enough water to the mother. So breast milk production is also decreased, and also there will be a usually there will be a pursued breast milk insufficiency. One is improper technique, then the apprehension of the mother, and the intervention by the caregivers, and the lack of facility for privacy. These are the problems usually we face in government setup, which leads to the dehydration fever and also the jaundice, which are otherwise we can prevent. Sir, Murli sir. Murli sir.
It was clear. Yeah. Yeah. It was nice to of infertility. On the rise. That breast priority for any.
Yeah, yes. Many couples after IVF, I have seen they go in for formula feeds, but I don't think it is because they are searching for easy ways, because many of the times the mothers are elderly and they have so many other problems, comorbidities like diabetes, sometimes hypertension, and many of them in IVF, in some centers, it is 100% cesarean. So that is also one problem, that the milk feeding is not started in the first hour. So because of all these reasons, it is rather more difficult for them to start breastfeeding. And also they feel they do not have enough breast milk. They have so many caregivers, they keep on telling this is not milk, you are not having enough milk, you may not have. So it is, I think, the caregivers who are more interested in going for the easy ways. And already they are feeling inadequate in not being able to produce a baby through natural means. And so already feeling inadequacy is there, and compound to that, they feel they are inadequate in producing the breast milk also. So because of that, they are very easily persuaded to go in for formula feeds. I feel that is the reason. Provided they are given sufficient counseling by some lactation counselor, or somebody who is a strong, powerful influence on them, I think they can be motivated to breastfeed their babies. So I think that is the only way out. But it is true that many of the IVF babies are being fed formula, not breast milk.
Hello.
But there are certain
Hello?
drugs like cabergoline which we use for preventing ovarian hyperstimulation syndrome. But that is used in the earlier part of the stimulation, not later. So when it is used in the earlier part, and by the time the lady is pregnant and she is reaching term and she is going to deliver, by the time the cabergoline has been stopped long back. So the cabergoline is not going to affect breast milk production. Almost all the other drugs, they don't have any effect on breast milk production.
It's reproduction not different from normal conception as well as breast concerned. It's one of the most that
Okay, shall I speak? Can you hear me? Shall I speak?
yes, 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 yes.
Okay. Okay, so this
Yes, we can
question,
hear
as you said, is such a common question. Now we have two kinds of mothers. Actually, now since the last few years, we have two kinds of mothers with this kind of question. One is the empowered woman who's probably got a good job or a government job maybe, where legislation now in India permits them to have 6 months of paid maternity leave with the sole idea of supporting breastfeeding, exclusive breastfeeding in the first 6 months. Our theme for the World Breastfeeding Week in 2015 was breastfeeding and work, let's make it work. And Government of India has provided women with this wonderful opportunity to breastfeed their babies till exclusively till 6 months by giving them 6 months of paid maternity leave. Now we have the other set of mothers who are underprivileged, who work in the unorganized sector, who are in small private institutions, who have to get back to work soon. And they're probably given 1 month's leave or 2 months leave. And these are the mothers who are in trouble. So the first group, at least we can sustain breastfeeding till 6 months. And then we can tell them about appropriate complementary feeding, how to feed more during the night, how to express breast milk, how to store breast milk at room temperature or in the fridge, the use of breast pumps and so on to the mother who has a good job or the empowered mother. Whereas the other mother has lots of trouble. And it's not really easy to insist on exclusive breastfeeding of up to 6 months in these women, because ultimately they end up giving a formula feed, and that too diluted formula feed, often unhygienic formula feed, and all the all the trouble that you have taken for them goes to nothing. So what we can do is to teach them how to give a safe alternative. So you can ask them to continue feeds at night, express some amount for however much they can give, and maybe give a safe milk substitute for the rest of the day. So 1 or 2 feeds of express breast milk and 1 or 2 safe substitutes. And in that case, the thing that we need to insist definitely is that no bottle feed should be given. It should be given with cup and spoon or gokarnam. It should never be given with bottle, because much worse than the formula is the danger of giving in a bottle. And bottle feeding, I'm sorry to say, it seems to be so rampant. It is much worse than before. You buy a tin of formula and the bottle comes free with the bottle, with the tin. And then the cycle of bottle feeding and infection continues. Even I started breastfeeding week on August 1st with on rounds by confiscating a bottle. So that was the beginning of my breastfeeding week. So we need to specifically give this message, put this message across what has been put on the screen, that formula is absolutely not acceptable and acceptable substitute for breast milk. It is just a food. Breast milk is a complex living nutritional fluid containing antibodies, enzymes, long chain fatty acids, and hormones, which just cannot be included in formula. And in the first few months, particularly, the baby's gut gets injured by formula and other feeds. So this message has to be conveyed whenever we advise a breast milk substitute. I think.
Yes, this again requires a need for sittings that the life. Srini sir,
Yes.
1.2 kg. Mother is feeding milk, but she is said that growth is not normal.
Next slide.
And she's always.
I'll just briefly recap on the nutritional requirement of a preterm IUGR baby. You can note here that a baby who is at discharge is usually feeding very well and probably taking an breast milk of more than 200 ml per kg. So a human breast milk will provide adequate calorie as far as the requirement is concerned. Only thing that may be required supplementation with proteins and calcium and iron. Okay, now coming to next slide. So how do what we need to know about this? So we need to know certain principles very clearly, that the catch-up growth that we aim at should be attained using breast milk only, not using formula. And as I said earlier, the supplements may be required. And remember the maladaptation and lean body mass. Okay, for lean body mass is what is important, and for that what is required is protein. Okay, so we may be need to use protein in the early stages. Okay, and the catch-up growth, when you go, it is usually achieved in the first 6 months, and 80% of the Ayurveda babies will catch up by around 80%. And some babies are genetically tuned to become IUGR, and you should not tamper with the nature. And it's always best to plot the growth in a standard chart like the Fenton chart or intergrowth chart. And always remember that the growth should not cross centiles. Okay, it should follow centiles, and you should be intervene only when it starts dropping centiles. Okay, now how do we tackle that? Next slide. Okay, now such babies will be in the NICU and will be doing KMC, and you need to discharge at the discharge advice. You need to counsel the mother regarding the nutrition very clearly and catch up growth and development, so that she has got her concepts right. Okay, and these babies need to be followed up in the high risk clinic preferably, and you plot the chart appropriately, and every time you follow up this baby, you emphasize the role of breastfeeding. Okay, and one thing is that what I always use is that usually these babies are smart, even though they may not be looks puny. So what I say is that brain is more important than brawn. Okay, and now the issue which usually starts around 3 months, again, this is because of the peer comparison, because when around 3 months the mother and the baby starts counseling and socializing, and it is at that time we have this peridal ceremony and all. That is when this comparison start. So the bottom line is that formulas feed should never be used in an IUGR for catch-up growth, and educating and counseling the mother with regard to the nutritional requirement and what is normal for an IUGR baby, and to dissuade the temptation to fatten up the baby should be used. Okay, thank you. Thank you.
Yeah, that important that when you're following up these babies, 3R babies and SGA babies, it is always to plot their growth against these standard growth charts. Then only we can tell the bystanders or tell the parents that the baby is growing in the standard way. It's no mean that who is no growing only sure, that's all. Many times we see breastfeeding the baby, but they'll powder and as I give some formula. So how will you to tackle this?
Sir, many times the parents and caregivers, especially the grandparents, will ask for a formula feed when we are discharging the baby from our hospital. Usually they will ask any medicines to be given. Sometimes they will come back after 2 weeks and will show us telling that you have not written any medicines for the baby. The baby may not need any medicine. The only medicine need is your mother's milk. But many times easy means lazy. They want something to be given to the child, and they want their child should be like as Srinivasan sir said, to be chubby. They compare with the neighborhood child in the neighborhood. And what's the problem with starting this formula feed even inside the hospital? As earlier said, when child have a hyperglycemia, symptomatic hyperglycemia, we may give sometimes a formula feed for 1 feed or 2 feed, but we will give it only inside the labor room or inside the nursing station do not showing to the mother or the grandparents. Otherwise, they will demand for every time they will demand formula feed to be given from the hospital. So even for a hypoglycemia, we will give inside the nursing station, not showing to the grandmother. And when we start and discharge on any formula feed, or when coming to the review, we are giving the formula feed for any reason, that will lose the lack of bonding, and the mother will have secondary lactation failure, and they will easily change the formula feeds, and they may not know the economical burden for formula feed. So usually they will start to dilute the formula feed. As Janaki Madam said, they will start diluting, and there is chance of infection, and all the effort we have done will going to nothing. So one is the conflict between this giving formula feed and advising breastfeeding, because sincerely telling, many pediatricians, even many general practitioners are liberally prescribing formula feeding for their child. One reason is that they want to know, they want to see that their children are growing fast. Even the mother demanding the pediatrician giving formula feed. Next time, easily gaining weight. So they will say that the doctor give medicine and he gain weight. The other pediatrician asking the mother, you give breast milk, you give express breast milk. It's very difficult for them. So they will find out an easy way and go to another pediatrician. So he or she will write down the formula feed. That is we are seeing in practice, and not blaming anyone. And so it will give a wrong message to the people also. And as also said, ma'am also said, there are some pharma companies which will promoting many talks or many scientific sessions, and they will come up with the new formula feeds with added honey, added iron, added apple, banana, many lot of things, and very colorful bottle, and they will promote these things. These are happening in everywhere, and also in general practice and government setup. These are also happening. We cannot say it's not happening, but that's the reality. So it will give a wrong message to the parents and the mother. One thing we have to do to prevent this is we should not, sir, next slide. We should not, we should do a growth monitoring every time. As Srinath said, what we are doing is that in our immunization card, there is a growth chart. So every contact point, like the first week of 6 weeks immunization, and so first 1.5 to 2.5 months, we should enter the weight and show the mother that the child is inside the green curve. So they will be happy, and tell them that when this your child is growing through the green curve, it's not a problem. But one problem is that ICDS is usually asking the Anganwadi teachers and these ASA workers to monitor the weight recording. But practically what is happening, once you visit the immunization clinic in government setup, you may not be even seeing the weighing machine in some places, because there are lack of supervision. I am working in government setup, but I know the facts. When pediatrician is sitting for immunization, some pediatricians strictly ask the ASHA worker to enter the weight on the growth chart before leaving the child. Otherwise, they will not enter. They will record the growth weight and tell the mother, or write down near the card, but they will not plot the weight in the growth chart, and they will ask the mother to and counsel them the importance of this growth chart. That is happening many times. And the comparison of neighborhood child are told. And another important point, we should counsel the mother. At the same time, we should counsel the grandparents. The grandparents are main caretakers, not the mothers. Even in our 6 weeks visit, the grandparent bring the child. They will not bring the mother. When we ask where is the mother, it was a cesarean section. She is not able to walk after 6 weeks. This is happening in many immunization clinic and even in our practices. So we should counsel the grandparent, and the mother should take the child. Mother should mother should give care to the child. I will usually say that Amma kutti eduthu nadannal ammakku paal undavum, amma kutti eduthu ammakku paal varilla. Adonde amma kuttiye paal eduthu nadakkanam, kondu nadakkanam, ammade methu kedatti orakkanam. Amma എന്തെങ്കിലും പേഴ്സണൽ ആവശ്യങ്ങൾക്ക് മാറുമ്പോൾ മാത്രമേ അമ്മൂമ്മ എടുക്കാവൂ. ഈ ഒരു കമന്റ് നമ്മൾ എപ്പോഴും പോസ്റ്റ് നാറ്റൽ വാർഡിൽ പറയാറുണ്ട്. So another point, I said awareness creation at each contact point. We should utilize the JPHN, ASHA workers, and also Anganwadi workers to create the awareness. Usually the immunization points or the immunization clinics are the first contact point for a child. As I earlier told, after discharge, the baby will go to mother's house, and from there, baby will go to the father's home. So we will not get a continuous follow-up. And except in medical colleges, in taluk hospitals or in district hospital, there is no concept of well baby clinic. Once even I asked our administration to start a well baby clinic, the reply was, if you are not there, who will conduct the well baby clinic? So we cannot start a well baby clinic without without such a post or without such an OPD service. So what we are doing, that when we two pediatricians are there, we will ask the children, babies discharge, they ask them to come on a particular day. So that particular day we will monitor the weight, and also we will counsel the babies. But because of the rush, sometimes may not be possible. So also we should create the awareness among the healthcare workers and even among doctors. So many of the immunization programs or many general practitioners are seeing the baby for first time in rural areas, especially in rural areas, not going to pediatricians. So one another service is that lactational counselors services should be extended to the periphery, to the field also. They should go to the field, and they should counsel the babies' parents in field. That will be useful if we are creating a post of lactational counselors. Otherwise, lactational counselor service will be only to the hospital. We will miss the follow-up, and we will not ensure the breastfeeding up to 6 months.
Okay. Thank you, Praveen. That again, that reiterates the need for a lactation and also the counseling the grandparents. That is the important point that we have to think. Lola, madam, that we are seeing mothers taking a lot of medicines, anticonvulsants, antipsychotics, anti-cancer drugs. So what is the effect of these drugs on lactation? And also any Ayurvedic granules they are usually prescribed for the mothers for the enhancement of milk secretion. And do you use any galactagogues? And if any, what are they?
Yes, several of the drugs used, like say aspirin, opioids, chloramphenicol, nalidixic acid, tetracycline, ketoconazole, nitrofurantoin, sulfas, metoclopramide, all these have adverse effects on the breast baby by passing through the breast milk. So ideally, many of them have substitutes. You don't need to really use most of them. Ideally, they should not be prescribed during breastfeeding. OCPs in the initial phase, like it may decrease, but once the lactation is established, if you give a low dose OCP, usually it doesn't affect the breastfeeding. But at the same time, having said that, I'll also say that for a lactating mother, the ideal OCP to be prescribed is a low progestogen only pill, that like Seracet, that is desogestrel, and that will usually increase the breast milk. It won't decrease, it will only increase the breast milk. But I think of this, the mothers are mostly aware, and they do not take OCPs at the time when they are breastfeeding. Now, but the question you asked specifically regarding anticonvulsants, yes, the problem is you cannot stop the mother from taking those anticonvulsants. So,
Hello. Hello.
Yes, you're audible, but madam has disappeared.
Yeah. I think madam has got some connectivity issues.
Actually, can go to the answers.
So I got some. That there are some studies in some centers uses metoclopramide also. Now miscellaneous. Nothing is in this practicing, breastfeeding practicing that you advise in these COVID times.
COVID is concerned, here we have again two situations. One is the baby who's born to the COVID mother or the COVID exposed mother, the mother in quarantine, the COVID exposed. Now, as per the current evidence, it's not COVID is not coronavirus is not transmitted through breast milk. So it's absolutely safe to have the baby with the mother bedding in and breastfeeding. So the practices remain the same. The recommendations remain the same. There's no difference. And there is a risk. There are such big risks of keeping the baby away from the mother. So that is not recommended. The WHO does not recommend separating the baby from the mother. Now the other experience that we have with COVID and the newborn is social distancing as a hindrance to counseling and support. Early discharge of the mother and the baby without lactation being properly established, without the anxiety if the mother who's already anxious because of COVID, the anxiety has not been allayed, and breast milk isn't flowing as it should flow. And she has reached home, and even when she reaches home, she may not get adequate counseling or adequate support from the family or from her friends or the neighborhood or the ASHA worker because no one is visiting her. The second thing is because of COVID and social distancing, you cannot go to the hospital as safely as you would before. And therefore, they do not go to hospital if they have any complaints. In fact, they have no one to go to, and they might go in for wrong practices, wrong feeding practices. And certainly financial instability, which has been brought on by the COVID pandemic, compromises maternal nutrition, maternal health, and as a result of that, infant health. Now, our experience at GMC Thrissur, both types of situations. At GMC, we have had around more than, I think, 32, between 40 and 50, 40 to 50 COVID-related deliveries, out of which very few, less than 5 were COVID positive. I'm not really sure the exact numbers right now, but COVID positive, and there was no transmission from COVID positive mother to baby. So that was okay. And they were term babies. Those positive babies, I think, were term babies and could be kept with the mother, had no problems. We did have problems with mothers who were suspects and mothers in quarantine who had preterm babies and babies who required neonatal intervention, required NICU, and had to be kept in the COVID NICU, had to be looked after in PPE till they were proven to be negative, or the mother was negative, and the mother and baby could be kept together and things like that. So that was one part of our experience. The other experience in this COVID time is that we have had a big number of, much more than usual, of admissions of young babies with malnutrition, very small babies with marasmus, 2-month-old, 3-month-old babies with marasmus, and babies with kwashiorkor. So that experience is much worse than before. We've never had so many babies in the same time. So that is another thing. And another experience that we have seen is that in the neonatal ICU too, we have had a little higher incidence of hypernatremia, dehydration, and AKI. So breastfeeding has been compromised by COVID-19, by the pandemic.
Okay. Thank you, madam. So my next question is to Srini sir, and this regarding preterm and multiple births. So can we keep these babies exclusive on exclusive breastfeeding? And what is the any role for preterm formula post care of premature babies?
The answer is a definite yes. Okay, a motivated mother will be able to feed a twin or triplet easily, and there is no role for formula. So before joining Amla, I was fortunate to work in a center which was an infertility center, and we had a quadruplet delivery. Okay, and this mother was so motivated but had so much support. So I always quote this mother, and she delivered quadruplets. All were weighing around 1 to 1.2 kg. Okay, the bottom line here is that you need to take care of her nutrition. Okay, first thing, especially during the early years, not only immediately after birth and immediate first 3 months, but throughout till she is lactating. Then she may have practical issues, because obviously when you have more babies, the babies may start demanding feeding at different times. So she may not have adequate rest, okay, for herself. So she may have to express the feed, and somebody else maybe need to give the babies an express breast milk. So in this particular case, which I talked about, they had 3 people, assigned people to look after. Okay, so that is one thing which we need to meticulously. So a motivated mother can nurse multiple babies, and it requires lot of support. Okay, now we are probably we are know about the wet nurse concept, especially in European countries. It's known that a wet nurse can feed up to 5 to 6 infants. So a mother can definitely produce enough milk for that. Okay, and I saw in one of the study that in a healthy mother of a triplet, they measured, and she produced around 3 liters of milk in a day, around 2.5 months of age. Okay, so definitely there is no role for formulas. Thank you.
It is really fascinating to know that a mother produces 3 liters of breast milk in a day. Really wonderful. Yeah. Praveen, it's a new concept that is coming in India and as well as in Kerala, the breast milk banks. And do you think that pasteurization of human milk will adversely affect its quality?
The breast milk banking, it's a modern human milk banking is in infancy period still now. It's almost 2-3 decades. First milk bank in Asia in Dharavi, November 1989 by Amaranda Fernandez. But after that, the idea couldn't get much importance or not much promotion for this idea. It's mainly meant for primarily for high risk newborn. So if you are starting a breast milk banking, we can do an exclusive breastfeeding in VLBW also, very low birth weight babies, also for the abandoned babies and the babies of mothers with postpartum illness and neonates at health risk from breast milk of a biological mother. In these conditions, we can definitely use the human milk banking. The problem with, next slide. Next slide, Melissa. Melissa, next slide. Sir, next slide. Sir is not hearing. The problem with the human milk banking is one is the lack of awareness for and also there should be there is a leadership deficit and the infrastructure and maintenance cost. It needs a separate facility with facility for pasteurization and also 6 or 8 staff for receiving and also nurse, and there should be a microbiologist, and also we should maintain records, and for technical support there should be a technician. So there should be a good investment for that for creating a human milk banking and also the maintenance cost. And in our country there is less neonatal setups. So but in Kerala I came to know that in some medical colleges and also in some private medical colleges the breast milk banking is coming up. In future it will be there, we can hope. So the next part of the question, the effect of pasteurization. What we are in breast milk banking, what is advised in is the Holder method, that is 62.5 degrees Celsius for 30 minutes, and in a shaker water bath method. We cannot use the large machinery which we use for the dairy farms. We are using here shaker water bath using holder method. It will cause a decrease in lactoferrin activity and also a reduction in IgA level. And there is no destruction of interleukins, and also the lysosome activities are retained in holder method. But the flash sheet method, there are studies which compare the effect of flash sheet method and holder method. But in our country, it's not using the flash sheet method or the high temperature short time methods or UV lights are not using in our country. We are using the holder method. This information I got from the IAP's guideline in, a few years back. That's all, sir.
Yeah. And we are happy to say that that Jubilee Mission Medical College Thrissur is going to have a breast milk bank, and also General Hospital Ernakulam is both two are going to set the first two breast milk banks in
We
Kerala.
also have got a sanction for a breast milk bank at Thrissur Medical College.
Calicut also, I think.
I'm happy to say.
Oh,
Very happy to say.
two.
I'd also like to add that there is a certified course for lactation counseling by KUHS. Just along with this, I just like to say that there's a certified course for lactation counseling by KUHS, and a lot of nurses have been trained by both KUHS and IAP and given certificates.
Okay. Good. Lalam is there. So, have you noticed any change in the attitude of mothers or grandmothers or doctors towards exclusive breastfeeding? If yes, what may be the reasons for the same? This is my last question to the panelists. Madam is there?
Yeah. Okay. Yes, definitely there is an increased awareness regarding breastfeeding among mothers as well as grandmothers and medical practitioners. And they have come to the realization that it is best for the baby. The reasons are probably the BFHI activities, then awareness about the benefits being propagated through the various media, the print media, TV, WhatsApp groups, and also all these magazines like Vanita, Arogya Masika, all these and the talks, the health talks given on TV and all these must be helping. So I think they are aware, and definitely the attitude has changed. Earlier, the grandmothers, they have seen only babies being bottle fed. They used to immediately bring a bottle. Nowadays, they don't do that. They also provide help in the feeding of the breast baby through the breast.
It is very happy to know that these BFHI activities and other awareness activities which are done by the government has got some effect, that we are seeing the change in the attitude. That attitude always matters. So I request each just one valid point in practice in your Praveen, tell something. Dr. Praveen?
I had not one, many points to say.
Yeah.
In practical issues, I agree with Lola Madam, there is a change. But when we were studying in Thrissur Medical College, the BFHA activities are going on, but I don't think it has changed a lot after that. Last decades, what we are seeing in
Praveen, if I ask you to select one point, which one you will select?
So one is the effective use of media that should be done during this technology period. Very influential media is very influential. We have not seen any advertisement promoting the breastfeeding, even from the government side or from any IAP side, or even media persons are not recognizing it's a social commitment to do such activities.
Yeah. Yes. Lola ma'am.
Yeah, if I would say for one point, it will be dedicated lactation and counseling. It should be made mandatory for the hospital to have a recognition.
Yes. Praveen has his slides.
Any hospital which has got a delivery of more than 100 per month should have a lactation counselor. So that should be made mandatory law. If a law needed, it should be passed. And also another thing is after the patient is discharged, the patient is being discharged by the 3rd day after birth. So after that, nobody knows what she's doing at home. So it should be followed up, like my earlier speaker said, ASHA workers and all those people, those who go to the houses,
Yes,
they must follow up and see that the breastfeeding is being continued and provide
yes,
encouragement, moral support and everything. Support is very important. And in
yes,
workplaces also, they should be given time to breastfeed, and also places where they can breastfeed in privacy, or at least places where they can express breast milk through pump and then give it to the baby, maybe by somebody
yes.
else. All these, if it is there, maybe we can enhance the breastfeeding practices. Yeah, and yes. So
Sir is also pro lactation.
Sir, it's not.
So the concluding remarks. Janaki ma'am is there?
I'd really like to emphasize antenatal counseling and preparing the mother for breastfeeding.
Yeah,
This
am I
makes
audible?
such a difference. Makes such a big difference.
Yeah, and am I audible now?
Yes, you are.
Yeah, sir. Janaki
Go
ma'am
ahead.
is keep speaking. You can speak after that.
Yeah, you can. I finished. Antenatal counseling is what
Okay.
I really want to emphasize.
Okay. Srini sir. Yeah. Carry on.
Now, one thing I want to say here is we all remember the NSS case, and when we used the healthcare worker for resuscitation, training them, just like that, we need to have the healthcare worker at the grassroots level to implement whatever we talked about, in order to improve all those trends in the breastfeeding, or to improve the breastfeeding in total in our state.
Yeah.
Sir Murli, sir, one more
So,
point. Sir,
yes.
one more point.
Yes,
This is an era of telemedicines and teleconsultation, especially the corona. We cannot sure that corona will end by 1 year or 2 years. So in a telecounseling, IEP can take an initiative to exclusively for the breastfeeding doubts and for counseling the mothers over the phone. We are not needed to visit the mother. Many times the mothers are not coming to the OPD or bringing the child now. Especially there is a government restriction that children should not be going outside. So mothers are not coming to the OPDs with such issues. So whether IAP can start a telecounseling platform for doubts regarding the breastfeeding, or for giving a number all Kerala wise, that will be a useful platform for mothers for the next 1 to 2 years at least.
Yes. That's a valid point. So to summarize today's discussion, we know that BFHI lags behind its goals. That's why today's panel discussion was there. And lack of motivation and an easy-go attitude always lose the harm. Another important thing is, like Jani Madam told, antenatal counseling and the 3rd trimester breast examination is very important. And start breastfeeding at or within 1 hour of birth. That is also very important. And the other party also we have to take care of, that is strict implementation of the available laws against infant milk substitutes. And breastfeeding and work, and let's make it work. And another thing is lactation counselors. I think probably the message to the administrative side of IAP or NF is about providing more and more lactation counselors. If we cannot do, or the nursing staff cannot do, let those people who are trained in counseling, let them do. That is very important. So coming to our here, that Shashi Kapoor says, I have Ma with me. What is Ma? Ma is mother's absolute affection. Thank you. Thank you for your patient listening. And I know that there was a lot of technical glitches, and I'm very thankful to all the 30 to 35 delegates who are still listening to this program, in spite of all those technical errors. Thank you.
Thank you, Murali. Thank you very much. Before concluding, I want one final comment from Purushothaman sir. Please, sir.
Muted.
Sir, mute ആണ് sir.
Sir, mute.
Sir, mute ആണ്.
Please unmute.
Thank you, thank you. There was a lot of problem. In spite of that, there's a wonderful lot of areas covered. And Dr. Janaki and myself belong to the government medical college, private on the Praveen from the private sector. I have an Praveen from the periphery government sector, and gynecologist madam is there, and Srini also from private sector. All the good blend was there. I had a feeling that there would have been a mother also who can share the successful experience in spite of the hurdles. And about the government sector, about one question was what about the postgraduate students? There are, in any institutions, there are at least 100 or more of the postgraduate students, maybe at least 10 lactating mothers among the postgraduate students. We should have a facility for baby care. They can pay the one person, and in between they can go and feed the baby. That should be there in all the teaching institutions with the postgraduate girls. So that is one important thing. And about the other thing, our experience in the antenatal counseling we did with the NRHM staff nurse who is dedicated for the immunization. All the other days we were using that staff nurse for antenatal counseling. And about Lola madam's truthful statement, and she was very truthful. Actually, that is what is happening. Antenatal counseling is very important, and bus examination is very important. That is to be done, and hereafter many meetings of combined meetings, OBG with the pediatrician should be there. And last year, why not? We had a perinatal meeting, and throughout the state there should be meeting of combined meeting, at least 2 per year. Then only we'll have a successful implementation. And one more very important, we should be picking up from the adolescent period. And adolescent girls should have examination by the parents. Praveen was indicating that grandparents should be counseled after delivery, but before delivery, the parents should be checking the adolescent girls about the nipples and all. So at least that part, that time itself, there's some problem can be picked up. So that is one important thing. And about the social media, which Praveen, then there is a lot of things social media can do, and your social media also. I think we can ask some mothers to contribute something about her successful experiences. So that can be taken up by the many mothers will be coming up with successful experience. Inspired there are a lot of mothers who had the bad experience till they somehow managed to feed, because it's not the lack of knowledge. They all wanted to feed, but some problems creep in and they are not able to. So how they manage to do these things? So sharing of experience by the actual person who are the mothers, that should be coming from the social platform. So we should be utilizing the social platform more, and that will be anyway. There was a lot of problems with of a bit bandwidth and of this. Still, the 2 hours we instead of 1 hour and 15 minutes, 2 hours we took. But the all the panelists and the moderator did a wonderful thing. You covered everything. So I hope IAP will take up and the Obstetricians Association will take up, so that this will all this matter we have discussed will be conveyed to the right persons. Thank you all.
Okay, thank you.
Thank you.
Sir, for the wonderful
Srijit, any other thing?
Okay. I asked Redhi Madam for any final comments. Actually, Redhi Madam is also not there. So actually,
May I say?
All the panelists.
May I say a word? May I say a word?
Yes, ma'am.
This is the first time that I have been invited to speak on breastfeeding at the IAP, and I really have a lot of. I'm really grateful for this opportunity for having invited me to speak at the IAP on breastfeeding, because it's a topic which is very close to my heart.
Okay. Okay, thank you, madam. Thank you, all the panelists. Actually, I personally thank Janaki madam, Purushothaman sir, Lola madam, and Srinivasan sir for the wonderful presentation. Also, the Praveen sir, and for the Murali Raj for wonderfully coordinating this session finally well. And thank you. And once again, sorry for all the technical glitches occurred during the program. And thank you for your patience. And I will. We have another program coming next tomorrow, the PG quiz tomorrow, and Manjusha will be hosting that. And see you then tomorrow. All of us from here. Good night. Good night.